Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode. During the question-and-answer session, you may press *1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I'll turn the meeting over to your host for today's conference, to Richard McKeon. You may begin.
Hello, this is Richard McKeon. I'm the Chief of the Suicide Prevention Branch at the Substance Abuse and Mental Health Services Administration. Apologies for the delay. We're having some technological challenges, but I couldn't be more pleased to be hosting this first part of a two-part webinar on suicide and intimate partner violence. Both suicide as well as intimate partner violence are each one of the major causes of death and injury in the United States. And reducing or eliminating suicide and intimate partner violence are major public policy priorities for us. Despite the fact that these are each hugely important areas that have many areas of crossover and many areas of similarity. For example, the need for screening and risk assessment, for crisis intervention and safety planning. There has been very limited interaction between the two fields. But we feel strongly that both fields can benefit and that we can do a better job of both preventing suicide as well as preventing intimate partner violence by engaging with dialogues of each other and reaching out to both the suicide prevention and intimate partner violence fields to find out what their needs are and how we can all work more collaboratively together. We have an outstanding group of presenters today. I will introduce our first presenter. Dr. Jackie Campbell is the Anna D. Wolf Chair and Professor in the Johns Hopkins University School of Nursing with a joint appointment in the Bloomberg School of Public Health and as National Program Director of the Robert Wood Johnson Foundation Nurse Faculty Scholars Program. She has been conducting advocacy policy work and research on violence against women since 1980 with funding from NIH, the National Institute of Justice, CDC, and the Office of Violence Against Women, and publishing more than 225 articles and 7 books. She is an elected member of the Institute of Medicine, chair of the Board of Directors of Futures Without Violence, and co-chair of the Institute of Medicine Global Violence Prevention Forum. In short, she is one of the nation's leaders in the area of prevention of intimate partner violence and intervention with that, and we are looking forward very much to her presentation. Let me just mention that, so I will be introducing each of our presenters, and then at the end, we will be opening it up for questions. We have an extended question and answer period from 12 to 1, which is also intended as an open forum when people can not only ask questions, but also give information about what you experience as your needs being in this area. So with that, I'm very pleased to introduce Dr. Jackie Campbell.
Thank you very much. I am delighted to be able to do this webinar, and it is a slightly bifurcated webinar. I am, first of all, going to talk about some data that we have from the ACAUSE study, the African Caribbean African American Women's Study, that is funded through Caribbean Exploratory Research Center, supported by the National Center for, now it's National Institute for Minority Health and Health Disparities. I'm also going to mention some data from another study that was funded from joint funding also, an R01 from NIDA and NIMH, CDC, and NIJ, and this is on the data on homicide-suicides, because I think both aspects are incredibly important, and I've been looking at that for quite a long while. You see in the slide in front of you the beautiful, the city of Baltimore, which is where we collected half of the data for the ACAUSE study, and their is St. Thomas in the U.S. Virgin Islands. And although it's the beautiful Mediterranean where people live is also very poor, very similar to inner city Baltimore. Next slide. The specific aims and methods of ACAUS is to determine and compare the prevalence of intimate partner abuse, which includes emotional, sexual, and physical abuse in a sample of African American and African Caribbean women. From healthcare settings, we recruited in primary care settings in both the U.S. Virgin Islands and in Baltimore. And to determine, and this is where this data comes in, to what extent a history of IPA is a risk factor for other medical conditions and symptoms, including mental health, and that's where the suicidality comes through. And so that's the part I'll be presenting today. We used mixed methods, an ACOS questionnaire, a computerized questionnaire that women could either use as touch screen or they could either read the questions or have them read to them over earphones, and it could be in either Spanish or English. We also looked at medical records and did in-depth interviews with a subsample of women. Next slide. Now, the next slide is a sample slide, and we have some technical problems. So if you would just go through, just keep clicking, and as I read. We started out screening 1,579 women. We ended up, when we screened for IPA, we found that we found 486 in Baltimore and 1,059 in the Virgin Islands because we wanted to have women from both islands in the Virgin Islands. We ended up with in past year, intimate partner violence. This is physical and sexual assault, not emotional abuse by itself. 963 women in the Virgin Islands and 461 in Baltimore. All the women inclusion criteria was that they had to be 18 to 55, and they had to have had a partner in the past 2 years. We ended up with 1,315 fully eligible women. We found there was a few problems in terms of eligibility for some of those women. Our final participants were 901, 348 from Baltimore, 159 cases, 189 controls. Controls had never had any abusive experience from a partner. And in the Virgin Islands, 553 women, 384 cases, and 169 controls. The next slide gives the demographic characteristics, and the only significant difference between Baltimore City and the Virgin Islands were there were more women, over half the sample were single in the Baltimore City, and even though they had had a partner within the past 2 years, they described themselves as single. While more of the women in the Virgin Islands were either described themselves as partnered or married. The employment also was significantly different, with more women in the Virgin Islands employed. In terms of prevalence, I think what's important here is to see the lifetime physical or sexual abuse was 32%, 33%, fully a third of the women. That was not significantly different. And intimate partner violence in the past 2 years, that's again physical and or sexual assault, 21.66%. Now the 33% goes along with most national studies. Past 2 years, 22%. That is higher than in most of our national studies for current abuse, and we consider past 2 years to be current because even if the partner is gone, there's still some relationship. The next slide shows just the comparison of depression using the CESD in the abused women versus the non-abused women. And this is the intimate partner abuse. So this includes women who are emotionally abused only. 34% of the women who are abused have been abused in their lifetime, experienced over the cutoff on depression with the CESD versus 6% of controls. PTSD, even a more dramatic difference with 19% over the cutoff on the Davidson Trauma Scale versus 1% of controls. Now, this is the suicidality just in descriptive comparison. And we did look at self-cutting, which for African American women, African Caribbean women, is considered relatively rare. We actually had almost 12% of this sample saying that they actually were doing self-cutting versus 4% of controls. And although that's not suicidality per se, we thought that was important to mention. We considered suicidality either suicidal thoughts or having made an attempted suicide in the past. And again, striking significant differences between our cases and controls, with 14% of our cases women who had been abused. And again, these are women who are not seeking help for domestic violence. They are in a regular primary care setting. So a really striking number of them said that they had attempted suicide. So when we looked at the odds ratios, being abused increased the risk by 10.55 of suicide attempts. And we did look at mediation. With depression, we found that depression did partially mediate, but not completely mediate the relationship between abuse and suicide attempts. So all of the suicidality is not through depression, which is important because we usually screen for depression in primary care, and we only think about suicide if people screen yes on depression. But significant numbers of these women not depressed were described themselves as having made suicide attempts. PTSD, we had the same partial mediation with PTSD between abuse and suicide attempts. We had the same relationships when we looked at suicidal thoughts, that depression and PTSD both partially mediated, but not completely, the relationship between abuse and suicide attempts. Next slide. I'm sure you're keeping up with me, Claire. I'm sorry. I keep forgetting to say that. On the next slide, this is the results of the doing a adjusted logistic regression and a multiple logistic regression. Our adjusted odds ratios were that the African Caribbean and African American women who were experiencing intimate partner abuse 2.63 times more likely to have suicidal thoughts, 4.14 times more likely to have attempted suicide than non-abused women. And importantly, if there was prior 2 years intimate partner violence, physical and or sexual assault, the women were 10.4, adjusted odds ratios of 10.4 more likely to have attempted suicide and or have suicidal thoughts. So these are really striking odds ratios, very striking and strong relationships. So we have seen the suicide and suicidality among women being strongly linked to intimate partner violence in this study and other U.S. And global studies. Importantly, Nadine Kaslow's, and she's going to be presenting at the next webinar, and also the multi-country study of violence and health outcomes that Claudia Garcia Moreno has spearheaded, shows abuse strongly related to suicidality globally. And in this country particularly, well, globally it's true also, but the ability to access resources is critical. The women in the ACOS study who had attempted suicide and or had suicidal thoughts were assessed for immediate suicide risk. So with the ACOSI system, one of the things that happens is if they had self-reported attempted suicide or suicidal thoughts, this came up at the end, and the research assistant then went immediately into a further screen for immediate suicide risk. And the majority of those women said that they indeed had a plan for suicide and that they thought about this plan frequently, but they were not planning to implement it immediately. So they didn't actually qualify for the psych emergency department kind of protocol. They said it was mainly because of children that they weren't going to implement that plan, but they did think about it a lot, and the majority of the women actually asked for some sort of counseling for the suicidality. And most of these women were poor, and most found it when we tried to make appointments for them, it was very hard to get any kind of appointments in a timely way. Sometimes people would say, well, we can see this woman in 8 months. And we were like, yes, but what we're saying is that she is having suicidal thoughts. She has attempted suicide. This needs to be seen more quickly than that. So we really had to press, and most women don't have that kind of access to mental health care services. And as we all know, the mental health care services for poor people in this country are very limited and very difficult. The other thing is that with our routine assessment for intimate partner violence in primary care, which is the new U.S. Preventive Task Force services recommendations, and there are also there's recommendations for screening for depression. So we definitely need to be assessing for intimate partner violence. But if women do disclose intimate partner violence, I think it's important that we assess for suicidality, even if they are not depressed. And the routine universal screening for intimate partner violence in all healthcare settings, we have to recognize that women may present with many symptoms and complaints that are seemingly unrelated to intimate partner violence. So it's very important that the screening be routine, and that our trauma-informed care and primary care include screening for both depression and intimate partner violence, and then if women are abused, being sure to assess for suicidality. The other suicide connection is the domestic violence, homicide, suicides. And in this country, when women are murdered, they're most often murdered by a husband, boyfriend, or ex, and only 5 to 8% of men are murdered by a partner, even though there's far more homicides of men. In this country, African American and American Indian, Native Alaskan women are disproportionately affected by domestic violence homicide. Immigrant women are at increased risk also, at least in New York City, where that analysis has been taken place. And when women are killed by a partner, domestic violence is the #1 risk factor. And it's also true when the man is killed by a partner, there's been prior wife abuse in 75% of the cases. Now, where suicide comes in is that women are far more likely to be the victims of homicide, suicide, and domestic violence homicides. And it's 29% if you look at the studies overall, of the domestic violence homicides, when a woman is killed, the male partner kills himself afterwards. The most common form of familicide, which is when more than one family member is killed in one incident, and this is from NVDRS data, the male partner kills wife, girlfriend, or ex, and then one or more children, and then themselves, and it's usually with a gun. Now, these are rare events, but even so, incredibly tragic, and it is a form of homicide, suicide that involves domestic violence that sometimes is not recognized as such. Next slide. So the data I'm going to present very briefly is a 12-city femicide study. It's another case control study. Here the cases are female victims of homicides. We looked at police records, and we also interviewed a proxy for the woman who had been killed. The proxy was a family member or a close family friend that she had confided in about the relationship and what was happening. Our controls in this study were abused women in the same cities. It was a random sample survey, and we used abused women since we knew that domestic violence was the #1 risk factor. We used abused women as the control so we could find out what was the what was the risk factors for these homicides over and above prior domestic violence. For the risk factor analysis, we used the women that were from 18 to 50 who had abuse history, who had been killed, and they were compared to abuse controls, and we had a total of 500 women in this analysis. We used, again, multivariate logistic regression. We put the variables in blocks, in first background characteristics, then individual and couple, then general violence-related variables, violent relationship characteristics, incident level, and finally interaction terms. For the homicide-suicides or femicide-suicides, because these were women that were killed, followed by the suicide of a male partner, in our data it was 32% of domestic violence femicide, so even a little bit more than when you look at this overall in the country. First we compared the femicides where there was suicide and the femicides without suicide, and then we did the same sort of risk factor analysis for the homicide-suicides. The next slide gives the results. First of all, again, to reiterate, there was prior domestic violence against the female in 72% of the cases in the homicide-suicide cases, and that was almost exactly the same as in the homicides without suicide. We found the same significant explanatory power for the same femicide-suicide risk factors as for the intimate partner homicide risk factors. These, again, were over and above prior intimate partner violence, and some of these were even stronger. So these risk factors are the same, that they are the strongest ones in both kinds of cases, with or without suicide of the male partner afterwards. But with the homicide-suicides, partner gun ownership, the man's gun ownership, increased the risk of the homicide-suicide by 13. Threats with a weapon beforehand, this had to be a potentially lethal weapon, increased the risk by 9.3. Threats to kill the partner increased the risk by 5.4. A stepchild in the home increased the risk by 3.1, and estrangement, in other words, she had left him, sometimes left and gone back during the past year, increased the risk by 4.5. And in the homicide-suicides, there was stalking in 76% of the cases, usually after she left. The next slide shows the risk factors that were unique to the homicide-suicide. So these were risk factors that were true only in the homicide-suicides, not in the homicides, domestic violence homicides of women without a suicide. And these were that the partner had threatened suicide. And for those of us that look at suicide, that's not a big surprise, but for oftentimes for domestic violence advocates, this partner threatening to kill himself seems like just another mechanism of trying to keep control of her. And because usually that threat is, if you leave me, I will kill myself. But we need to be sure that our domestic violence advocates and women who are in violent relationships understand that this is a realistic threat, this is an important threat, this is something that needs to be followed up on. And the problem is in these domestic violence relationships is he may kill her also and then kill himself. There was also a history of poor mental health in a lot of these men, and many of the perpetrators had been seen in the mental health care system or by a family physician for depression oftentimes, or being depressed. And oftentimes these symptoms started when she left him or threatened to leave him, and that's when he would become depressed and distraught. These men were more likely to be married than the men who killed their partners and did not kill themselves afterwards, and they had somewhat higher education levels. unemployment was still a risk factor for the men who killed themselves afterwards, but oftentimes the unemployment was after she left him. Then he either became worthless at the job and got fired, or he just quit, stopped going because he felt like nothing was worth doing. These men were a little bit more likely to be white. So in their presentation, they were less likely to have been arrested for domestic violence or any other violent crime. So in their presentation to any parts of the system, they don't look like what many people think an ordinary domestic violence offender would look like. They're more middle class, they're higher education levels, and slightly more likely to be white than the regular domestic violence homicides, but that was disproportionately African American. So there are African American men who kill themselves after they kill a partner. So the conclusions here, the femicide suicide perpetrators are unlikely to be known to police, but may be part of the system in terms of mental health or physical health system. So we need to learn how to assess men who come to either the mental or physical health system for domestic violence perpetration, as well as assessing everyone for victimization. This is especially important in the mental health care system and in substance abuse treatment and in the VA system. Some of our VA, our veteran suicides are homicide suicides, although that's not tracked very well, unfortunately. And we found that when women were killed, 47% of those women were in the healthcare system in the year prior. So that's another way to identify these potential homicide suicides is through the abused woman. Overall, 83% of our cases of homicide, domestic violence homicide, were seen somewhere in the system before they were killed, before the murder occurred. And the last slide is just a quote from one of the moms of the homicide suicide victims that I interviewed. Thank you.
Thank you so much, Dr. Campbell. That was an amazing presentation with incredibly important information. But next, I would like to introduce Dr. Kate Ceruli. She is the director of the Susan B. Anthony Center for Women's Leadership and Laboratory of Interpersonal Violence and Victimization, and an associate professor of psychiatry at the University of Rochester. The National Institute of Mental Health awarded her a 5-year grant to conduct a randomized controlled trial in family court to assess whether enhanced mental health enables intimate partner violence victims to better navigate safety. She's also co-principal investigator on a National Institute of Justice award to assess whether victim participation in prosecution impacts their subsequent safety. She was formerly an assistant district attorney in Monroe County, New York, where she created a special misdemeanor and domestic violence unit in 1995. She's been working on issues surrounding domestic violence and child abuse for almost 3 decades. She currently has funding from the Centers for Disease Control to work with the National Intimate Partner Violence Hotline to help address the intersection of violence and mental health. She works internationally to ameliorate violence against women and is currently assisting with a project addressing the health and welfare of sex workers and trafficking victims in Laos. She is a founding and current board member of the Crisis Nursery of Greater Rochester, Incorporated, a grassroots organization providing emergency respite care for Greater Rochester area families with young children. I have great pleasure in introducing Dr. Catherine Ceruli. Kate?
Thank you so much, and thanks to our hosts for doing this. It's such important work. Because we're having some technical difficulties, Chelsea, I'm going to have you start on slide 13 for me. For the viewers, I wanted to let you know I've included some information in the beginning of the slideshow about current prevalence rates and sort of basic information about domestic violence. If you're a domestic violence provider, this is simply repeat information to you. If you're new to the field, this will be helpful background information, or if you want to share it with community partners, feel free. I'm going to start with talking a little bit about how my work takes off from Jackie's work and Jackie's work influencing my work. The venue where I frequent the most is family court, and I believe civil court is a real opportunity to be thinking about suicide prevention, both from the perpetrator side of the fence, which Jackie's just shared with you some information on murder-suicides and what some of those warning signs are and risk factors, and also on the victim side of the fence when survivors come to family court seeking protection orders. So starting on slide 13, one of the themes that we were seeing in family court was the incredible, overwhelming physical health burden of people coming to court. And again, as Jackie said, some folks are connected with care and some aren't. The physical concerns have been largely documented. And if you go to the next slide, the psychological concerns have largely been documented as depression, post-traumatic stress disorder, and those sorts of things that were indicated earlier today. However, some of the other psychological concerns that arise for some of the people coming to family court is anxiety that presents itself in ways that makes it difficult sometimes for their providers and attorneys to work with them. They feel that the survivor stories don't sound complete, that they're wandering. The survivors won't come back to court, indicating that the very physical place of court causes tremendous stress for them. And the next slide, looking at social concerns, many of these women are controlled and men who are victims are controlled by their partners, leading to social isolation. Well, all of these three things combined, if you go to the next slide, the biopsychosocial model of health, where you're looking at psychological, social, and biological factors really creating health. When you overlap fear of an abuser, fear of the isolation, fear of disclosure, fear of stigma, coupled with the stress that many of these survivors feel, it leads to this complete exhaustion and impaired function. And my work at family court, very similar to Jackie's work, we do see many people, and I'm going to talk more about the numbers later, coming to court who say, yeah, I think about killing myself. In fact, the last time I thought about it was this morning. Next slide. The numbers that have been coming out about why the cost to the community, healthcare systems, incarceration systems, there hasn't been, from my perspective, a really good cost assessment looking at the cost to the communities for intimate partner violence. We had a homicide happen. It was perpetrated by a woman who was a survivor, and that one case cost our community over $1 million. When we think about cost-benefit analysis, they often look at the health system side, or they look at medical treatment, or they look at the criminal justice side. We haven't really had a study to trace these murder-suicides and suicides down the road in communities to look at both sides of the fence. So the next slide, really my work has been focused on what are we to do. We know violence is a global health issue. We know that we're trying to do something, but I guess my question to the community is what's the bike helmet for domestic violence? Where are we going with being able to prevent these? And because the next slide, suicide is so integrally connected, suicide and murder-suicide. And when we think about suicide in relation to intimate partner violence and murder-suicide, we have the victims, we have the perpetrators, we have children who are witnessing and children who are sometimes also feeling suicidal because of witnessing or being exposed to partner violence. But we also have the bystanders, and in a homicide study that I did about a decade ago and looking at homicides, there were murder-suicides that were never, as Jackie said, calculated as murder-suicides because we don't have great tracking mechanisms nationally, but there's often bystander trauma, and as the quote indicates at the end of Jackie's slide, this impacts families and communities for life. Next slide. In sharing with you some of the early research around suicide, next slide, we know that victims present throughout primary care, emergency department, psychiatry, and pediatrics. We know in the next slide that in relation to their OB-GYN visits, we're looking at the impact of birth control and whether they can control birth control, how it's used, how it's destroyed. And for some survivors that we've interviewed, thinking about connections to having many children or being overwhelmed or finding out that they're pregnant, a pregnancy they don't necessarily want, can also be issues for them. I'm going to skip the next slide. It's just an overview, and Jackie presented that quite well. The next slide, when we think about homicides, suicides, and suicides among intimate partner violence, I think this graph is telling this is not rates, this is numbers. So the if we had rates here, it would look quite different. But this is what's been leading to our work to think about where can we start to do some of this homicide, suicide prevention work. We know they're in the medical communities. We know they're in mental health communities, albeit not as often as perhaps they would want to link or can link. We know that they're touching the criminal justice system. But when you see the startling statistics from Jackie's work and her colleagues' work, if these aren't folks the police are seeing, and these aren't necessarily folks the mental health and health communities are seeing, where are they going? So we decided next slide to start to think a little bit out of the box in terms of what do we call perpetrators. We sometimes call them perpetrators, batterers, respondents. But when we label them in that way, we're assuming in some ways that they've come into one of our systems, that they're a perpetrator in the criminal justice system, or that a domestic violence shelter is turning them perpetrators or a respondent in a civil court system. So we pushed the envelope back a little bit, and we started to think about the next slide, thinking about picking them up in court sequences in different places, family court, divorce court, bankruptcy court, criminal court, maybe before the level rises to violence or before we get to the edge of that cliff. Can we push back the suicide, homicide prevention work a little bit more? Next slide. And one of the things that we're doing in an effort to do that is thinking about hotlines. We know that there is high use of hotlines. The Suicide Prevention Center at the University of Rochester received a CDC grant to prevent suicide, and one of the projects I'm going to be presenting now, you can see here the investigators, consultants, and our community partners, we came together and said, how can we think about preventing suicide on a domestic violence hotline? If we know the interconnectivity between these issues, we know that perpetrators and survivors call the hotline, do we have a chance to intervene before these individuals may either make connections with or be seen in another system? Next slide. So the study design is essentially partnering with the National Domestic Violence Hotline. We've recently visited and done some pre-training observation. We did silent monitoring on hotline calls, and we are asking the hotline advocates what would be helpful for you to know about suicide. They receive tremendous training in this facility, but when you're busy learning about all aspects of assessment, screening, and referral, suicide may not get the attention that it needs or deserves. And we created, next slide, a self-monitoring instrument where we can look at the calls that are coming into the hotline and ask hotline advocates, do the callers express hopelessness? Are they feeling overwhelmed, fatigued, feeling useless, that they have indecision, difficult to make choices, that they're thinking about suicide? We've created this self-monitoring instrument, which you see before you as a draft, but we're in the process. It's been revised, and it's going to be actually tested, and we're happy to share it with people. And then what is the response from the hotline worker? Are they expressing empathy? Are they exploring the invitation? In the silent monitoring that I did, there were actually calls coming in which both provided direct suicidal thoughts, plans, and also some that were more discreet and that needed a little bit of prompting. If you go to the next slide. While we were in Texas, we asked the advocates if they would share with us their experiences, and we held focus groups, and we're in the process now of coding and transcribing those focus group transcripts. But one of the things that we learned, not a surprise, is that suicide is an issue for hotline advocates. Those that have received extensive training in suicide prevention feel very qualified and have great self-efficacy in identifying suicide on the calls. They feel quite safe asking about it and addressing it. We do know that many advocates are called to this work because they may have personal histories of being a survivor, have family members who are survivors. And also, just as intimate partner violence touches so many of us, suicide touches many of us as well, where we have family members, friends, and others in our lives. So we need to really think about a merging of these two issues and think, how can we give support to hotline advocates who are doing this very difficult work in identifying not only now a public health issue of intimate partner violence, but a public health issue of suicide, where these two issues converge. Next slide, please. So one of the reasons that suicide becomes a sticky issue on the hotlines is that many survivors are calling this as their frontline call. They may never pick up the phone and talk to anyone again, and if we refer them to a suicide hotline, we have no way of knowing that they'll actually call. So by preparing hotline advocates to be able to address suicide, we don't miss that window of opportunity if the connectivity doesn't come with a referral. One of the concerns for hotline advocates, if they transfer a suicidal domestic violence caller to a hotline, is then what happens? Does 911 get called? Emergency services? Does the hotline service have caller ID? So there needs to be some thoughts about protecting the anonymity of domestic violence hotline callers and thinking about how we can help them without them necessarily having emergencies show up at their door. The other issue, at least for the national hotline, is that if they transfer their calls, they will likely end up at their local state suicide hotline, and they worry about overwhelming that call center. Next slide, please. The second project that we're doing to explore these issues around suicide and intimate partner violence under the CDC grant is creating a community characteristics profile for all counties in the United States, and we're combining Bureau of Labor Statistics, crime reports, Agency for Healthcare Research and Quality, known as AHRQ data, CDC all mortality data, social capital files, and area response files. We're hoping to create this master community characteristic file based on the year of 2010 and be able to dig into that data and test some models for some of the studies that have come out, such as Jackie's 12-city site. This would be secondary data. It's de-identified, but nonetheless, we think we can begin to put together some mathematical models that explore what some of the community characteristics are for the things that we see happening at an individual level. If you look at the next slide, one of the things about this community characteristic data file is that we'll be combining health, criminal justice law, religion, and death data all into one data set, which we hope will lead to some policy recommendations. The next slide, please. How the two projects are connected is we have these associations and connections in the data file. We're able to hopefully include some of those in our hotline training, which we'll be testing in the field in November, and be able to think about disseminating and implementing some of these connections. The ultimate idea is to move these things into policies where we'll be able to explore a little bit more how we can help people who are facing both these issues together. Next slide, please. The work that we're doing at the Center for Disease Control Center Lab in Rochester, as well as the lab that I run, is based on community-based participatory research principles. So each of the projects that we have involves survivors in each stage of the process. Survivors are at the table in thinking about the design of the study. We recognize them as a unit of identity, as experts in their own knowledge, and that we co-learn together. So our research team is learning from the survivors as hopefully they're learning from us, and there's a cyclical process happening. The other piece of our CBPR projects around suicide and intimate partner violence is trying to move things into the field and get feedback right away. Next slide. Some of the earlier works that our lab has done is looked at suicidal ideating among respondents in family court, and it was not a big sample, but what we did learn is, in fact, family court is a place to potentially think about doing suicide prevention work. From the perpetrator side of the fence or the respondent side of the fence, 13% roughly had histories of suicide attempts. Although the attempts weren't recent, the threats were recent, and many of them had suicide threats, which you saw in Jackie's work as well. If you go to the next slide, one of the things in family court that we noticed, if you see that suicide threat circled, the dark green shows that about 70% of survivors have partners who have threatened suicide, which we know from the danger assessment that was created by Jackie is a risk factor for a whole host of bad outcomes, including homicide and murder-suicides. Yet, when you look at the light green, less than 20% of the survivors that come to court to file for protection orders actually share that information with anyone. So the green that is light shows what the judge knew. The dark green shows what we knew when we followed up with the survivor after court. So one of the things that we want to be doing, and we have a current Robert Wood Johnson grant right now, which I'll explain in a little bit. The Robert Wood Johnson grant is taking the danger assessment, actually training the intake workers at family court to see if we can better assess for that. Next slide, please. The other thing that's important in thinking about suicide as a risk factor in the orders of protection is, without knowing the danger level in these order of protection applications, we're really basing legal decisions on extra legal information. How did the woman present? Does it seem to be a case? Without the decision makers, the judges or hearing officers actually being armed with the information that they need. This small chart, which is from an article in 2012, shows that the temporary orders seem to be based on some connection to the danger level, but when you look at the permanent protection orders, we start to see fluctuations in that. So we want to be thinking about our judges making decisions based on these suicidal threats, and other risk factors that we know are true. The next line. Again, looking at suicidal petitioners also presenting an opportunity for family court to be an intervention site. We learned, similar to Jackie's work, that about 17% of the victims that we interviewed indicated current suicidal ideation. And in my particular community, some of them read the paper in the morning, see somebody who's been killed, who had it was a domestic violence victim, and sort of feel that sense of hopelessness. Next slide. The current Robert Wood Johnson grant that we're doing is basically examining what the process is in court, what is the intake process, and then considering whether we can change the intake process to be able to use evidence-based instruments and make decision-making in court more, in some ways, scientific without losing the essence of that individual judgment. Officers may get low scores on the danger assessment but still feel that there's a level of danger there, but they can't necessarily explain, but their red flags are going up. Next slide. One of the things in merging the two fields of suicide and intimate partner violence together in our work is really trying to think about the intersectionality of race, class, sexual orientation, gender, socioeconomics, education, intimate partner violence histories, and mental health, and how we weave these disparate fields together. In many ways, the fields have been separate, and the funding streams have been separate, so to try to be thinking in the future about weaving these things together. The next slide, please. So the clinical implications for the work that we're trying to do is to really prevent some of the bad outcomes that we've been talking about. But this includes also, juveniles who might kill a parent to protect the other parent, and also to think about the community being protected from the outcome that they have. Next line. For those of you who are researchers on the call, I just wanted to share with you there's a couple of publications that have come out on thinking about domestic violence ethical research concerns. Next slide. And issues that arise, of course, having people disclose such painful situations, where we do it, how we do it, openness with the researcher, the gender of the team, fear, shame, retribution, and child welfare concerns. In one of our studies, we had some child welfare concerns yesterday, and addressing those in a way that's ethically responsible. Next slide. Some of the remedies are to ask behavioral questions, try to stay away from stigmatizing language, being judgment-free, and really looking at the World Health Organization guidance, safety being a priority in the work that we do, and having appropriate referrals for care. Next slide. And one of the issues we talked about also is if we know that we're trying to do prevention work, suicide outcomes have a low base rate, and it's very hard to recruit very big samples with small grants or smaller grants. So one of the things many larger grants offer the option to is longitudinal studies, and the question we need to be thinking about in studying suicide and homicides and domestic violence outcomes is thinking about longitudinal studies and really allowing it each follow up the participants' autonomy to be able to continue to participate and not to feel necessarily hounded by the research. The next slide, in conflicts and thinking about, we're asking people about suicidal ideating, suicidal threats, plans, but one of the conflicts in some ways is that we turn around and we tell them in our informed consent, if you share with us that you're suicidal or there's harm to your children or we think that you're a danger to yourself and others, we're going to report you. So we have to work through with our community partners and survivor advocate informants how we're going to handle these issues in a sensitive way, because by having our informed consent provide that very necessary information required by HIPAA and our federal and state research laws, we don't necessarily want to shut down these avenues of research. Next line. So where the rubber hits the road is basically thinking about this as an issue for ongoing lines of research and being able to work with community partners and roll this research into the community. Next slide. We protect our participants. I just want to put a shout out for people to be thinking about the participant safety, but also our own staff safety. If you're working in a domestic violence shelter or those settings, to be thinking about these suicidal calls and the homicides that occur create great trauma for our staff and the people who are working in this field. And one of the community partners that we're working with has an amazing vicarious trauma program and really allows their individuals to get help when they're dealing with these. Next slide. One of the other things about intimate partner violence and suicide is the anonymity in reporting because it is a low base rate phenomena. So when some of you are seeing newspaper reports and we're reading about these cases, it's very easy to put the cases together and to be able to re-identify things. So I think it's important to be respectful of that understanding that these stories can often be woven back together. The next few slides I'm going to have Chelsea skip through. These are simply an overview for you on suicide research concerns, not necessarily related to intimate partner violence, but things that I think can be helpful and woven into intimate partner violence research as well. The last slide is slide 57, where I think the blueprint for change really has to come from the science, the practice, and the resources. What money and funding is available in communities, where can we be doing suicide prevention work, what's going to work, and what does the data tell us? And I feel like we have about 2 decades of suicide research and intimate partner violence now. We have decades of mental health and health research. We have decades of service research. I think now it's time, and it's exciting that you're going to hear from Dr. Caswell on Friday, it's time to be thinking about what interventions are going to be able to prevent these outcomes. And hopefully the hotline study that we're conducting and the Robert Wood Johnson study that we're conducting about bringing research into practice in these community settings will shed some light on that. Thank you.
Thank you so much, Kate. Those were both fantastic presentations, and we really appreciate them and the work that you're doing. I know if some of the folks listening in are like me, that you're probably thinking about how to absorb all of the information that's being presented. That's so important. And I did want to mention that this will be archived on the Suicide Prevention Resource Center website, which is www.sprc.org. So if you felt like you missed something, there will be ways for you to re-access that information. I would now like to introduce our final speaker, who is Jake Fawcett. Jake is the coordinator of the Domestic Violence Fatality Review at the Washington State Coalition Against Domestic Violence, which is a membership organization of 65 shelter and advocacy programs in Washington State. Since 1997, the Fatality Review Project has brought interdisciplinary teams throughout the state to take a critical look at the community response to domestic violence. The Fatality Review makes recommendations to increase safety and self-determination for survivors of abuse and to increase community capacity to hold abusers accountable. Jake is the author of the 2010 report, Up to Us, Lessons Learned and Goals for Change, after 13 years of the Domestic Violence Fatality Review. He is the father of 4 young boys, more than enough reason to be passionate about violence prevention and building healthy communities. So with that, I will now introduce Jake. Thank you.
Good morning. Thank you so much. I am just really pleased that we're doing this, and I'm really happy to be part of this conversation. It's been great listening to both Jackie and Kate, and just excited about the research that you all are doing and hearing more about that. Let's see. Am I able to control the slides now here?
Yes, you are.
Chelsea, I guess I can just push the buttons and find out. Thank you. So I'm going to talk a little bit about what we have learned in our project over the last 13 years, as Richard said. And I'll just give a really brief overview of what the Fatality Review is for folks that are not familiar with that. I really just want to echo the points that both Jackie and Kate made about how important this intersection is between domestic violence and suicide, both for the suicide risk of victims and also the murder-suicide connection. And it's something that we have been paying attention to since we started doing this Fatality Review process and looking at domestic violence homicides and murder-suicides in 1997 in Washington. And as both of y'all pointed out, we just haven't had as much connection between those fields and haven't seen that really take root in the kind of practice that people are doing yet, especially in healthcare and mental health and law enforcement and with judges in courts and with domestic violence advocates as well. We're starting to see that, and I just think it's really an important conversation. So I'm really very happy that we're doing this. So our work is based in looking at domestic violence, homicides, and suicides, and some of these numbers will echo what Kate and Jackie both talked about. But in Washington State, consistent with around the country, nearly half of women who are murdered are killed by intimate partners. And just to give you a reference point for the kinds of numbers that we're looking at, we keep track of any homicide and suicide that's related to intimate partner violence. And the numbers that we're looking at from 1997 through the end of this past year, 2012, are 615 people in Washington State killed by an abuser, and 908 total deaths, including abuser suicides and including some cases where the abuser was a homicide victim. So our process, we bring together an interdisciplinary team in a local community. They're organized by county in Washington State. And to take an in-depth look at a one-person story at a time. So we want to look at a situation where somebody was killed as a result of domestic violence. And our purpose in doing that is to go back in time and look at everything that happened before that murder or the murder-suicide and see where were all the different points of intervention, what led up to that event, where were the places where the response could have been better, and what needs to change as a result of what that group learns. So the teams that review those cases are made up of domestic violence advocates, batter intervention people, mental health and health care folks, and law enforcement, prosecutors, judges, people from churches and other community-based organizations. We try to get as broad of a group around the table as we can to ask the questions. And the questions are coming from, there's a couple different principles that we're bringing to that really inform everything about what we learn. One is to look at it from a systems perspective, that we're looking at how did these systems function, what was the community response, as opposed to trying to find, what was the one thing that somebody did wrong, or where was the one thing that caused this murder to happen. We're also looking at that we're starting from the center of the victim's experience. And so it poses a different question when you ask, what did this person need who was being abused? What did this person need, and did she get it? And if she didn't get it, why didn't she get it? We get really different answers when we ask that question than if we ask the question of, did these systems do their job? When the person went to, when they called 911, did the police do what they were supposed to do? Did the judge do what they were supposed to do? Because what we've found is that very often those answers can be yes, the systems all function the way that they're supposed to function, and yet it still doesn't get the outcome that we want. It still doesn't get the person who's being abused the safety that they need or the choices that they need. So out of that discussion come these practice recommendations, and that's what our work is rooted in here. Just briefly on how we actually define what is a domestic violence fatality and what goes into our thinking, we're looking at intimate partner violence, so we're not including child abuse homicides or murders that are of family members or household members that meet the legal definition of domestic violence but are not intimate partner violence related. We're just focused on intimate partner violence in this project. But we are looking beyond a domestic violence victim killed by a partner. We include murders of friends, family, new partners, law enforcement officers that are killed in the context of an intimate partner violence relationship. And suicides of abusers are a big part of that. Most of those are murder-suicides, but we also see an attempted murder and then a suicide. Or sometimes there are situations where there is a suicide of an abuser, and it's clear that that's happening in the context of intimate partner violence, and we will also include those cases and look at those. What we're not including for the most part in the numbers that we're gathering and in for the most part in reviews, are suicides of battered women, of domestic violence victims. And the reason for that is that we just don't have a good way to track it. So there's no real way for us to look at suicide deaths and know which ones of those are happening in the context of abuse. We get most of our, I think it was Kate maybe that mentioned just trying to actually identify which murder suicides or which homicides even are domestic violence related. There isn't one real simple way to do that. We do it a couple different ways, but what we start with is we look at newspaper articles, and we have a clipping service that searches for us of any murder in Washington State that has written up in the paper and that has something to do with domestic violence, and we comb through those and figure out which ones meet our criteria. Then we use some other information from police and law enforcement and courts to supplement that, but a lot of the information comes from those news reports. There isn't one kind of surveillance system from police or anybody else that can identify the murders that are related to intimate partner violence in the way that we're defining it. So what we have seen since the beginning of this project is that about a third of domestic violence murders are murder-suicides, where the abuser kills his partner or someone else and then kills himself immediately after that. It's something that since this project was founded in 1997, we've been talking about and noticing and trying to make this connection and figure out what that means. So what I'm going to talk about is a little bit about what we've actually seen in the numbers, but more about what that looks like on the ground, both for survivors and for people that are working with them, for advocates, law enforcement, and others. So this is the suicide of abusers and murder-suicide is overwhelmingly men, almost all men, 96% in Washington State. All of my numbers here are coming from Washington State. Of abuser-suicide deaths are by men. We include, when we just do a number of abuser-suicides, we include those killed by law enforcement often in those numbers. Most of those fit a definition of what police call suicide by cop, of somebody that is in the midst of a domestic violence assault, and law enforcement responds, and the abuser pulls a weapon on the police and refuses to follow orders, and there's an attack, and the law enforcement responds and shoots and kills that person. So we often include those in our suicide numbers, and for both of those categories, the suicides and those killed by law enforcement, almost all of those are by men. So a couple of things that we've looked at. We did a study on protection orders. This was this was published in 2000, so it was before that. Where we tried to compare a random sample of domestic violence protection orders with protection order narratives in cases that resulted in a domestic violence homicide. And what we were looking for was homicide threats and suicide threats. And what we found, these are percentages here that are showing on the screen, was that 100% of the reviewed fatality cases had either homicide threats, suicide threats, or both. And 40% of them had mentioned suicide threats. In the random sample, there still were, 35% of them included homicide or suicide threats, but it was much lower. And what that helped shed light on was that looking at this connection, we often heard from judges or from other people, well, everybody makes those kinds of threats, and you can't take those seriously. So what we were trying to do is point out that not everybody makes those threats, and that it actually does indicate that there's a higher risk when there are those threats of murder or suicide. In our 2006 report, we looked at how many of all of the suicide deaths, how many of those had a prior domestic violence history. So we had this way of knowing how many domestic violence murders were murder-suicides, but we weren't able to figure out, well, how many suicide deaths are connected with domestic violence. So the way that we did that was for 1 year in Washington State, we looked at all suicide deaths, and we looked at history of domestic violence victimization for women and perpetrator history for men. Now, when I say that, it's a very narrow way of looking at that because, of course, we weren't able to do interviews with people or to go and do case reviews. what we did was we just searched court records and looked for domestic violence protection orders, criminal domestic violence no contact order, or in the case of men who we were looking for perpetrator history, we could see if they had a domestic violence criminal charge at any time in the past. So for men, what we found, we looked at 457 suicide deaths in just this one-year snapshot, and we found that 1 in 5 of them had this documented domestic violence history before the suicide death. To me, that was really striking because we know that that's really a tip of an iceberg when we look at the criminal charges and protection order history, that in most cases of domestic violence and in most domestic violence homicide cases too, those abusers and those victims or survivors are not seen in court before the murder happens. They're not calling police for the most part. They're not charged with domestic violence crimes. They're not getting domestic violence protection orders. Fewer than half of domestic violence murders do we see a prior protection order or a criminal charge. In the case of the criminal charges, it's way much fewer. Out of 84 case reviews, 48 of those had any kind of domestic violence call to the police at all. This is just including a 911 call. And out of those, less than half of those calls resulted in an arrest, and then only a very, very small fraction of those ended up in a conviction. So just for a point of comparison, in 2003, the year that we looked at these suicide deaths, of the murder-suicide perpetrators, only one of them had this documented history that we were looking for. Sorry, I'm skipping ahead too fast. We also looked at suicides of women for the same one-year snapshot, and we looked for how many had been previously protected by a domestic violence protection order or a criminal no-contact order, and found that that was 13%. Again, that's even more of an undercount than it is for looking for the abuser history, because we don't have a corollary to the criminal charge. We weren't able to look for someone who was the victim in a criminal case. And again, looking at the women killed in a domestic violence homicide in that same year, it was more than half of the women, of all of the murders of women for that year, and none of those domestic violence murders had a domestic violence criminal history or, a protection order or no contact order history that came up in this set. So what we have seen is a reflection of what the research shows that Kate and Jackie both talked about, was that the connection here is that abusers' control tactics make all the risk factors for suicide worse. The isolation, the hopelessness, and the depression, and also that there are real barriers to accessing mental health care. And some of those are just a material barrier that the abuser is actually creating, where he's making it harder for her to go get mental health care, making it impossible, in some cases, for her to actually get outside help. And the other barrier is that mental health providers often don't do a great job of understanding domestic violence, of addressing that. So they may not see domestic violence, they may not screen for domestic violence, they may not recognize it when they see it, and they may not see someone being abused as a cause of their depression, as something that's contributing to their substance abuse, and instead have a point of view of, well, this person is being battered because they're using drugs or alcohol. They're being battered because of their depression or their mental illness. And it can be I'll just say from the point of view of looking at where people are actually turning to for help, it's hard to underestimate how much care there is out there and services and resources that people are getting that is just very badly informed about domestic violence. So we know that there are excellent mental health providers, and they're great models, and there is really good information and training that's out there. And that's just a small percentage, a very small percentage of the support that people are actually accessing. So, people will go to excellent therapists some of the time, and much, much more often they're going to somebody in the community that they can find that may not have really any information about domestic violence. or more often couples counselors or pastoral counselors, somebody at church, these providers who really don't have a lot of training about domestic violence at all. When we started talking about victim suicides, what we found, and I just want to echo this from I'm really excited to hear about the national hotline work, Kate, that you're doing. What we found is that there's just a huge demand among domestic violence advocates for information about this, for training, for having that equipment when advocates are working with survivors on safety plans and helping support those folks. We have done after this 2006 report, that kicked off for us a collaboration with a suicide prevention project here in Washington State, and just really simply what we did was cross-train. We offered training for their folks. They came and did a couple of trainings for us. We did webinars. We had trainings at our conference for advocates about suicide, about suicide prevention and intervention, and about self-harm. And then we connected people locally with here's a suicide prevention person that's working in your community, and here's a domestic violence advocate, and just have each other's phone numbers, invite each other to meetings, get on each other's radar in that way. That was a really fruitful thing for us to do, and I think a great model. And what I took from that was that every time we had any training or webinar or anything to do with suicide and self-harm, they were absolutely packed, standing room only. Advocates really want this information. What we see with the murder-suicides is that there are these themes in there about how these cases look that may be different from the risk factors for suicide for men who are not abusive, that it's not just about the abuser's depression or suicidal thoughts, but that the themes that really come through strongly in these murder-suicides are the abuser's desire for control, his rage, his desire for revenge, his really wanting to be the one that wins, to not let that control get away, and this consistent thing that we've seen a lot of casting himself as the victim, of really thinking of himself as somebody that has been harmed by the victim in the relationship. When it comes to suicidal threats, one thing that we have seen out of these case reviews is that suicidal threats are used by batterers who are suicidal and who commit murder-suicide, and they're also used by batterers who may not be suicidal and don't commit suicide, but do kill someone else. So we see suicidal threats as a fairly common tactic among batterers who eventually commit domestic violence murder, even though there's no suicide or even a suicide attempt. Sometimes I think what's happening is that it's an implicit homicide threat, or it's a threat of violence that goes under the radar, because when he threatens suicide, it doesn't rise to the same kind of level of attention as murder threats do. It doesn't get the person arrested. It doesn't bring that other kind of intervention. So it's a way of threatening violence that can slip by. And that sometimes what we've seen is that those suicide threats get identified by either mental health folks, counselors, friends and family, judges, law enforcement, as that's just an attempt to manipulate her, and therefore it's not a real threat. And what I just want to reinforce is that those kinds of threats may be manipulative. They may not be a sincere suicide threat, but it's still dangerous and still indicates that he's more of a threat to his family, if not to himself. We've really seen that both healthcare and mental health providers just don't recognize suicidal threats as a danger to the victim. They don't routinely screen men who are depressed and suicidal for domestic violence, look for indications that this person is abusive or controlling or has used violence in the past. It's just, for the most part, amongst the providers that we've talked to, people that have been on review panels, the experts in how mental health services are provided and how counseling works in local communities, for the most part, the consensus is this is not on the radar. So that is what I am really hopeful that we can shift as part of this conversation. Part of that problem is that there aren't really good tools to identify abusive men. We have, or abusers, abusive women either. We have pretty good tools for identifying survivors, for identifying victims of domestic violence, of somebody who's being battered, but how do you actually look at the person in front of you and figure out, is this person using violence against their partner? Are they controlling their partner? Are they somebody who's a risk to someone else? What are the questions that you ask? What are the protocols? How do you ask that? Who do you ask? Do you ask the man in front of you? Do you ask his partner? How do you figure that out? And, of course, one of the big barriers to asking those questions or trying to figure that out is that providers don't know what to do if they hear yes. So if there's no if a healthcare provider or a counselor is not confident about what they would do or has no idea what they would do if they see that danger, then they're much less likely to look for it or screen for it. So just one example, and I think Jackie, you'd mentioned that many of these murder-suicide perpetrators, they're seen in many of our systems, but often not in courts and not in law enforcement. So just one example from a reviewed case, this man was a recent combat veteran. He had a history of suicidal threats, pretty severe alcohol use and abuse. And there were threats of suicide and self-harm that were documented in a protection order that his wife had petitioned for an order and said that he talks about suicide and self-harm all the time. He was getting a lot of intervention. He was in alcohol treatment. He had inpatient mental health treatment at one point. He had been prescribed medication for depression. He had some of these screening and services through the military. But none of that was looking at domestic violence. No domestic violence intervention came out of that. None of those providers were screening for domestic violence. That connection never got made in any of those systems where he was receiving care. In fact, we looked at 80 of the 80 case reviews that we did up until 2010. In 20 of those, healthcare providers had some specific information about abusers' depression or suicide risk. So not only had they seen a healthcare provider, but that person had prescribed them medication for depression. They had talked about suicide or suicidal thoughts. And even in those cases, they didn't screen for violence. They didn't recognize that suicide risk was also a risk to victims. And again, I'm sure this is an undercount because we're dealing with public records here. We don't have access to confidential health records. And so these are just in those 20 of those 84 cases were the ones that we were able to identify from interviews, from police reports, from public information. Where we have seen real shifts over the time that we've been doing this work is in domestic violence advocates recognizing abusers' suicidal threats and suicide attempts as a threat to victims. So now if a domestic violence advocate, at least this is true in Washington State, I think it's true many places around the country, that if a domestic violence advocates are much more likely to routinely ask about suicide threats and see that as a red flag, a danger sign, and are able to talk with women about that and safety plan with women about that. Part of that is due to Jackie's work and the danger assessment and attention that's come from that. Law enforcement, I think, is a little bit hit or miss, but we're starting to see, again, partly because of the lethality assessment work that Jackie's done, suicide risk, abusers' suicide risk as an indicator of lethality, as an indicator that this person may be more likely to use violence against their partner, to actually kill their partner. And the other piece of that I think that's helpful for law enforcement that helps them tune into this is the idea that an abuser who's suicidal is also a threat to officer safety. That law enforcement officers see domestic violence calls as dangerous, and they are. And one of the reasons is that so many of these guys are suicidal, and they are just as likely to turn a weapon on a law enforcement officer maybe as the victim themselves. As far as judges in court, that has not happened as much. I think it hasn't quite that message hasn't gotten through as much as these other disciplines, but it's starting to. So paying attention to suicide threats and protection order petitions and seeing those as more lethal, and also using past suicide threats, suicide attempts as an indicator of lethality when you're looking at things like, am I going to release this person in front of me on personal recognizance? Am I going to hold them on bail? Are there going to be conditions on the release that are going to protect the victim's safety in this case? We're starting to see that, but it's very, I think there are these pockets where that message has gotten through, and judges are really paying attention to that, and it's definitely not the norm at this point. Again, suicidal abusers in the case reviews that we looked at had contact with lots of different systems. You know, not some with law enforcement, some with protection order courts, but many where there actually really is a real opportunity to intervene here if we're asking the right questions, if we're looking for the right indicators, and if the people who are doing the intervening know what to do when they find it. So we saw people get care from therapists, from the VA hospital and mental health systems, from the military. They did call crisis lines. They went to school-based counselors and employer-based counseling. There were cases where employers recognized that something was going on with the abuser, or had heard him make suicidal threats and required that person to go get counseling as a condition of employment. Many times drug and alcohol counseling was involved, whether that was court-ordered or otherwise. Couples counseling, a lot of couples counseling, a lot of pastoral counseling, a lot of folks trying to get help, reaching out for services and support wherever it may be available. Probation is another place where there's somebody who is potentially monitoring, looking at risk factors, and trying to figure out, is this person how big of a risk is this person and how big of a threat is this person? And if they are not they're not asking about suicide, if they're not paying attention to suicidal threats, if they're not looking at the fact that this person has committed a domestic violence offense and is on domestic violence probation, has also attempted suicide, if they're not seeing that as a risk factor, then it doesn't put the resources toward prioritizing that case as something that really needs to have some special attention. And that's what we're seeing. And we're seeing that, you know, as there's funding cuts and there's fewer and fewer resources available, a lot of domestic violence that is in the criminal system is misdemeanor level. It's a domestic violence assault 4. It's a misdemeanor assault. And it's those misdemeanor cases that are being, deprioritized, and the monitoring and probation for those being defunded. And we need a way to be able to pay attention to which of those cases are the ones that really are dangerous and need some attention. And this is one of those lenses that we need to be looking at. I've seen, when we look at domestic violence prevention and we look at domestic violence homicide prevention, it's been my experience, and I'm curious if other people have had this as well, that there's some resistance to seeing domestic violence homicides as preventable. I think partly it's because they're rare, and partly because it's traumatizing, it's baffling, and it is hard for a community to understand and accept when these events happen. But I have found that in some of the communities where we try to talk about this, that there is a little bit of resistance, and sometimes a lot of resistance, to seeing these as something that we can prevent. Our focus is really in the fatality review less on trying to prevent murders themselves as looking at the response to domestic violence as a whole, and what can we learn from fatality reviews that can help us improve that whole system. But there is this kind of pushback sometimes of, well, this is a 1 in a million thing. You could never predict it. And that comes out stronger in my experience with murder-suicides and with the familicide, where, a man kills his children and kills himself, or kills his partner and his children and himself. That there's this real strong kind of cultural strain of wanting to think that that's something that is so outside the norm that we can't predict it and we can't prevent it. And so that's something that I'm curious if other people have had that experience, and how we might get information more into the kind of common knowledge about that, because the reality is that these things they are rare, fortunately, but they're not unpredictable. They don't come out of nowhere. There are indicators that come before you can trace the story back, and that's what the Fatality Review does, and look at what happened leading up to that murder-suicide. It's not out of the blue at all. A couple other areas that I just wanted to bring up and think that we should be paying attention to as we're having this conversation. One is the connection with veterans and veteran suicide. We've seen in the news reports and research that there's been this increase in suicide deaths among veterans of combat. I'm wondering whether there's also an increase in domestic violence and an increase in the risk to partners and children from those vets who are traumatized and having increased suicide rates. There's one study that from a while back in the Air Force that had a suicide prevention program. The intent of it was to decrease suicide risk. It not only decreased the risk of suicide, but it also decreased family violence at the same time, which was not one of the outcomes they were looking for. It was just something that happened coincidentally, but it pointed to this idea that there's some risk factors in common, and that the prevention can really be tied together. The law enforcement thing I talked about already, but looking at what's law enforcement training, because when somebody is suicidal or when there's a murder-suicide, that law enforcement training, if they're not looking at that as both a potential murder and a suicidal person, how do you tie those things together in law enforcement training, in looking at how you might de-escalate that situation? When it comes to officer safety, we looked at all of the law enforcement officers who were killed in Washington State, and a third of those were in response to a domestic violence incident. And the firearms thing, I will just point out very briefly that both of you mentioned. It's a much higher rate of murder-suicides use firearms than murders, and I think there's some real opportunities there in looking at where are the points in protection order petitions to actually intervene and make those situations less lethal. We see that 57%, this is a stat that's come out recently that's not ours, but of mass shootings, which are defined as 4 or more people shot, are domestic violence related, and many of those are murder-suicides. So as far as, I will just leave this slide up, but as far as where we go from here and what we've seen is needed in community level response to domestic violence, the awareness of that connection is a big first step, and for most communities, we're not there yet. That's the first step, is just actually getting the information out that there is a connection between domestic violence and suicide, and for mental health care providers to be paying attention to that. Some guidance about what we should actually do about that. And community education about domestic violence is a place to talk about those suicide threats, that for friends and family, for survivors themselves, to have the information that when you hear those threats, that is a danger sign, is a really important piece of information. Developing suicide prevention strategies that are specific to somebody that's controlling their partner. So it's not just looking at their suicidal behavior, but at the controlling impulse and at the violence against somebody else. Pairing safety planning, that when we're talking about safety planning, we're always pairing that with support planning for survivors. That I think that is another key thing. And finally, just this collaboration, that having these conversations and making connections on the ground in the field between domestic violence advocates and people working in suicide prevention is an important thing and a practical thing that we haven't gotten into as much yet as we should. So I'll end there. I think I'm past my time, and thank you so much for the conversation.
Hey, Jake, thank you very much. So in a moment, what we'll do is that we'll be opening this up for questions and comments. First, what I would like to ask my colleague Chelsea Booth here at FAAN, if you can just go over for folks who are listening in when part 2 of this will be happening and who the presenters for that would be.
Of course. So our part 2 for this webinar will be Friday, September 27th from 2 to 3:45 p.m. Eastern Standard Time. Our presenters will be Dr. Mary Louise Kelly, who is the Director of the Family Violence Division in the U.S. Health and Human Services Administration for Children, Youth, and Families, Dr. Carol Warshaw, who is the Director of the National Training and Technical Assistance Center on Domestic Violence, Trauma, and Mental Health, and Dr. Nadine Kaslow, who is Professor, Vice Chair, and Chief Psychologist in the Department of Psychiatry and Behavioral Sciences at Emory University. So I will be sending out the information about that webinar to all of you who were only able to get on the phone and were not able to get on our web platform. In that, I will also be including a link for this archived webinar on the Suicide Prevention Resource Center's website page so that you'll be able to view the slides that you weren't necessarily able to see then. So I thank you all very much for your patience. And operator, I think we are ready to open the lines for the question and answer period.
Thank you. At this time, we'll begin the question and answer session. To ask a question, you may press star 1 on your touch-tone phone. Please unmute your phone and record your name clearly when prompted. To withdraw your question, you may press star 2. Once again, to ask a question, please press star 1 and record your name.
And also, if you're more comfortable typing in your question, if your screen is not in the full screen mode, you should be able to see the Q&A line at the browser, at the top of your browser. You can just type a question in there, and I will be monitoring that and asking questions if you'd prefer to do it that way.
Let me, this is Richard McKay. Let me start with a first question for our panelists. That should we be thinking as a rule of thumb moving forward that regarding issues of screening and assessment, should part of what we be trying to communicate to the field is that anytime somebody is suicidal, that there should be a screen for domestic violence that takes place. And conversely, when there is evidence of intimate partner violence, that there should be a screen around suicidality. So if any of our panelists care to weigh in on that, I would be very grateful.
This is Jackie Campbell, and I would say yes, that these kinds of connections make clear that needs to happen. And, there are short screens for suicidality, and if somebody says yes, then you can go into longer screens for immediate risk or immediate danger of suicide, and vice versa. But I think it's not happening in either settings the way it should, but I would say yes, that should be the rule of thumb.
Yeah, this is Jake, and I agree with that. I mean, that's certainly what we've been saying, and we've seen it happening now with domestic violence advocates. But when it comes to the place I think we just don't really know how to do that is with mental health. When men are suicidal and depressed, how do you do screening for domestic violence and controlling behaviors in a way that's going to identify those folks and get them intervention that will be helpful? And that's the other piece that's really important here is when you identify somebody who is abusive, what's the intervention that's actually going to be effective?
This is Nadine Kaslow. I've joined, actually, and I would echo the yes answer. And I would add that I think it needs to be structured into these assessments. So I think it's routine in mental health settings to do a suicide assessment. And it's actually more likely for them to ask whether or not you were abused as a child than whether or not you're being abused right now. And I think it really needs to be, not only do people need to be trained, but all these online assessments and structured assessments need to include it.
This is Kate Ceruli. I agree with everything that's been said. And also, while I think that we can do the training in assessment and how we ask the questions, I think providers have to collaborate across disciplines, because in working in a department of psychiatry, many providers, are afraid to ask these questions, not knowing the next step. So I think the training needs to include not only standardized assessments, but bringing in community partners and agencies to say, hey, our door is open 24/7. I often say to people locally, our domestic violence provider is the best deal in town. It's open 24/7. can get a hold of them anytime, and it's free. So I think partnering with those community agencies, if we're implementing universal screening for either issue or them combined, which I support, I think we have to have those partnerships built so we don't leave providers hanging with information and that dilemma, where do I go? It's 4 o'clock on a Friday. I can't reach my preceptor.
And I would also like to add that there are a number of researchers and clinicians who are working with questions for identifying perpetrators in answer to Jake's question. But that is something that we do need to do more research on. We've done a lot of research in how to identify victims. We have a number of screens that have been shown to be very sensitive and et cetera and so forth. But we haven't been able to get funding for the work to identify perpetrators. And then you're right, Jake. I mean, then what? So if you identify a perpetrator, we need to do the same kinds of things that we have done in terms of giving people resources for victims, in terms of how do we help perpetrators get the kinds of resources they need also. And you know, does it have to always go through the criminal justice system? And I would say no, and that we need as much trauma-informed interventions for perpetrators as we do for victims.
I absolutely agree with that, and I think it's a really key. I mean, having that in place is the key to having providers actually do the screening, because in practice, people don't screen when, if they get a yes, they don't know what to do with it, or they don't think there's any good options of what to do with it. And that's a question we just haven't answered. I think that looking at the connection between suicide and domestic violence for abusers might be a place that could lead us in a good direction here. I mean, if we see that suicide prevention also reduces domestic violence, then maybe that will lead us to coming up with an intervention that's going to be effective. But if we don't have that, then it's hard to make the case that people should screen.
All right, so we do have a few questions from the audience if all of you presenters are ready. The first one is from Amanda. She first says that the information has been overwhelming, but in a good way. She educates about domestic violence prevention, and she has about 15 minutes in front of a military, medical, and medical support audience twice a month. Given that limited time, what does the panel feel is the one most important thing to convey to that critical audience?
This is Jake. I would just say that when someone who has used violence, when an abuser is suicidal, that their partner is at risk as well. And just that simple connection is not well known.
Yeah, I would definitely agree, and just some notion that many of these suicides, although we're not counting very well, and that's one thing I would say that we need to work with the VA system in terms of making the links of the homicide-suicide so that they can demonstrate that that there is risk to the partner in their data, but to convey that some of these suicides are involving homicides, and that many of the suicides do have prior domestic violence as even if it's not a homicide-suicide, many of the suicides, that's clear that prior domestic violence, prior marital problems is a huge risk factor. And so, that kind of information also, I think, helps make the case.
And, Jake, I think this is a follow-up question for you, but the person wants to know, is what you said true for both men and women?
Which part of what I said?
I don't know. That is the only part of the question. Deb, if you could hit *0, and you could say your question. Is that a possibility? Okay.
One moment.
Oh, got it.
This is Kate. While we're just waiting for Deb to answer her question, I just wanted to state that I agree with everything that's been said, but I also think that there's great research out there. If people look at Deb Horry's work and Karen Rhodes' work, we know that perpetrators want to talk, and we know that they will share information, and we know that they find healthcare a safe space to do that. But I think we have to be careful of the language that we use in labeling people and the questions that we're using, because that's distancing. So, by putting it into language, I ask all my patients this, or I ask all my providers, or all of my patients this, or all of my clients this. And I think we can push the bar associations a little bit more too, because they're seeing these folks for divorce, custody, visitation, bankruptcy, land claims, wills, trust, estates. We're frequent flyers with these individuals as well.
I really appreciate that. And in your note about what language we're using, we just can't assume that domestic violence is an issue for the criminal legal system. Aside from the problems that that system has in solving domestic violence when it does go there, most of these cases don't ever get to the criminal legal system. So we just can't. I think that's important to talk about all the other places where both survivors and people that are abusing show up.
Operator, do we have Deb available?
Yes, ma'am. And once again, if participants would like to ask a question over the phone, please press *1.
Oh, sorry.
Deb, your line is open.
Hi, thank you for taking my question. It was about somebody had stated, one of the presenters had stated that if a person is suicidal, their partner is at risk too. And so I wanted to know if that is true for males and females. So if a male is suicidal, his partner is at risk, and if a female is suicidal, her partner would be at risk.
Okay, this is Jake, so I'll let the other, let me just clarify what I was saying about that, that if somebody who has abused their partner is suicidal, their partner's at risk. The thing is that we don't always know who those people are because there's not necessarily a police report. There's not necessarily a protection order in place. So I would say that means that when you have a man who's depressed or suicidal, that's something to pay attention to look at, is this person abusive? Are they controlling their partner? Have they used violence against their partner? For women, no, I don't. The researchers can talk about what the rates are, but basically, these are such rare events anyway, and for murder-suicide by women and domestic violence homicides by women is just extremely rare.
Okay, thank you.
I show no further questions over the phone.
I have one other question I wanted to ask our panelists. One of the things that SAMHSA does through our suicide prevention programs is that we fund youth suicide prevention programs that have now gone to 49 of the 50 states and several dozen tribal communities, as well as college campus suicide prevention programs. So my question is there work that you think would be important to do through those types of grants? I noticed that Jake has worked with the Washington Youth Suicide Prevention Coalition. Are there recommendations that you would have about some of the work that could or should be done within the context of youth suicide prevention efforts or college suicide prevention efforts?
This is Kate. There have been some great studies done across different countries on the connection between suicide, intimate partner violence, and college campuses. And we've been doing some work on our college campus around looking at the connections that we know to be true across generations regarding mental health and domestic violence. And I would be a strong advocate of when youth are coming into health settings and school offices and college campuses, that if they're presenting with any sort of distress, that we be thinking about talking about these two issues with them. And, we've seen plenty of national headlines, that murder-suicides and suicides related to intimate partner violence are not isolated to adult populations.
Thanks, Kate. Anyone else have any thoughts on that?
And
Yeah, I mean, I'll just say that the collaboration that we did was on the local level with people that are working in their local communities on suicide prevention, and then with domestic violence advocates, and just as simply as connecting those people together and doing some training really was a way for those folks to just take a big leap in their understanding of both those issues.
I do show one more question in queue.
And I have a comment and a few other questions as well, but why don't we start in the queue?
Our next question comes from LaQuisha Burke. Your line is open.
Yes, I was just wondering if you guys could repeat the website where the information, the PowerPoints and stuff was going to be available to review after the conference call.
Yeah, if you can email me at it's CHELSEA.BOOTH SAMHSA.hhs.gov. I will make sure that you get the link for that. The link is a bit long. It's at it's at sprc.org, but I'll send you the direct link.
Okay, thank you.
All right. Well, then while we are seeing if anyone else is on the line, one comment from someone listening says, one intervention opportunity that wasn't mentioned was lethal means counseling by providers. CALM training is on the best practices registry at sprc.org. So CALM stands for Counseling Access Lethal Means. Then a question from Deborah. In a workplace, would you agree that the key would be information to the management with referral and consultation with the Employee Assistance Program?
This is Jackie Campbell. Can you hear me?
Yes.
Okay. I've been trying to make some comments, and somehow I got muted by the system. But anyway, I am about employee assistance. I think that's an incredibly important place where, again, people need to be routinely screened for domestic violence relationships, and that some of this training about the connections with suicide need to be put in there, as well as some of the other health outcomes, and employee assistance be shown that they can actually save workplace absenteeism, as well as a lot of health care costs by paying attention to domestic violence. And I wanted to back up to two other topics, two other questions that came in. First of all, in terms of women who are suicidal, who are domestic violence victims, as Jake said, they very seldom kill their partners, and there's almost never a homicide-suicide by a female against a partner. Women do kill their partners. Prior domestic violence against them is the #1 risk factor. But there's been very little research on other risk factors that are operating besides that they're being abused when they kill their partner. One very early study, Angela Brown, did find that suicidality was a risk factor for women killing their partners, but that was done way back in the 80s. So that kind of research needs to be done so that we can find out whether or not these women who are suicidal also that the homicide is a possibility for them. The other thing I wanted to say in terms of college campuses, we just had a domestic violence homicide suicide involving a student at Salisbury University in Maryland just last week. And it was one of those, media portrayals is very unfortunate about these things in terms of it seemed to be totally out of the blue. He's a really nice guy, et cetera. He was not a university student. She was. The other big media remarks were, well, thank goodness there's no other students are at risk, because he killed himself. That was the other message that was being portrayed. But it does bring home that our universities need to do a lot more around addressing domestic violence proactively in terms of prevention, but also, very importantly, making sure that victims of domestic violence understand if they're at high risk. And the One Love Foundation has supported us putting a danger assessment on an app that's specifically geared to young people that's available for free. It's One Love Light, and you can also download it from their website. And that's the kind of thing that I think that our college and university students may find appealing. And we need to figure out how to get these messages out to the young couples around the homicide-suicide potential connections.
This is Jake, so I'll just add a couple of things here. I think that idea about making sure that victims understand their risk is really important, and I think that what we've seen is that very often, the victim understands the risk, not always, but often understands the risk and is the person who has the most information about what her risk is. But there is a leap then to what can you actually do about it, and how are the systems going to respond, and where is the system that's going to respond effectively? So, for example, just in looking at protection order petitions, if a woman who's being abused knows that she's at risk and feels that she's at risk for homicide or an assault and goes to get a protection order, the number one thing that is going to reduce that risk is, if there's a weapon involved, is getting the weapon out of the hands of the abuser. And yet we have laws in place that say that somebody who has a protection order against them or has been convicted of a DV crime isn't allowed to possess a firearm, and yet that's just not enforced almost at all. In Washington State, it's almost not enforced at all, and across the country, it's largely not enforced, which means that if you go to get an order and the gun doesn't get removed, that order is much less effective. So I think what that leads back to is that people understanding their risk is one thing, but actually having a person understand their risk and then act on that really depends on there being something that you can do that's going to be effective. And people are just much less likely to want to acknowledge that risk or talk about it or go get help for that if they don't think there's any help that's going to actually help. And I guess the other thing I wanted to add for the employee assistance program, I agree that's a really important place to be paying attention to domestic violence. One thing I would add about that is when it comes to screening, there or in lots of different settings, is that I just think we need to look at whether asking screening questions is the right approach or whether giving information universally is the right approach. That a setting like an employee assistance program, asking a screening question, that may not be a safe place for somebody to actually acknowledge that they're being abused or that they're using violence. It may not be a place that a survivor has any interest in disclosing that they're being abused. They may not see any advantage to doing that in some place like an employee assistance program or even with healthcare providers. And so our motto around here these days is don't ask, just tell. And that in situations where we know there's a really high rate of domestic violence, that it happens to a lot of people, that instead of screening, asking the questions, are you being abused, and then waiting for a yes before we give the information or the referral, to just go ahead and give that to everyone. And in healthcare settings, I think that's important also. We've heard from from prenatal care providers who have really long relationships with women. I mean, the advantage they have is they see somebody over many months and go into their homes and all kinds of things, who say that they ask these screening questions of everybody. I've talked to providers who have said they ask these screening questions of everybody, and they've never once had someone say yes to the screening question at the first time they asked it. But after many months of getting to know this person, they have eventually found out that she is being battered and that she does need the support, and that instead of waiting for somebody to disclose, there are some of those places where we can just go ahead and offer the information, and that is more effective.
This is Kate. I appreciate what you said about the EAP program and sort of other short-time type providers. One of the situations that clients will tell me is they can't believe they spent hours telling their whole story to someone who then referred them on.
Right.
And for some people in the throes of things, it's very traumatizing to tell their story over and over and over. So, I think in terms of giving providers the skill set to know, you know what, I might be the only person she's ever going to talk to. I better do it right now. Or I really sense this person's, got an interest and they're going to make the call and they're going to have that intrinsic motivation to make the call. My concern, and I don't believe enough science has been done about this, is, when you're only going to see that person once and they're not going to reach out to somebody else, what happens?
Yeah, I agree with that. I just think if we can think about shifting the screening idea a little bit so that you're not waiting for somebody to say yes before you give them the information that they need to get support.
Right. Yeah.
Okay. And, I would say, Jake, that we would want to screen and tell, ask and tell, because if you ask, I always say women will decide who and when to disclose to. Just because we ask, we don't have to say yes. But we need to ask to give them that chance to say yes. And give them information no matter what. I agree with that. But I think that especially in healthcare settings, we have found that if we tell providers just, ask if you think there are indicators, then they put their own, lenses of who they think an abused woman might look like or who might be an abused woman and who wouldn't. And so that we say you have to ask routinely, universally, give people a chance, but that doesn't mean you don't ask again. Like we train our prenatal care providers to keep looking for it, even if they don't say yes the first time. But if you ask that first time, you're indicating you know something about it, you're interested, this is important. They can think about whether or not to tell you the next time you ask. We say in our prenatal care, we tell providers to tell the person they're going to keep asking. This is something they ask routinely because it happens to so many women. There are resources available. But failing to ask is also a problem.
Yeah, and I completely agree with that. I think what you're describing is asking in a way that's giving information and is an invitation for somebody to share their story if they want to. But what sometimes that gets played out when you just tell everyone to do universal screening is then once that gets when that actually plays out on the ground, what it looks like is somebody asking the question so they can check off a box and not offering information unless the person says yes and goes out of their way to disclose. So just screening as an invitation and an opportunity to offer information, not as a gateway or a barrier.
Okay, we have a few more follow-up questions. The first, Rosemary asks, do you all have any comments on research regarding same-sex domestic violence?
I can say that we did have a few same-sex couples and that were same-sex female couples in the multi-city risk factors for femicide. We found many of the risk factors the same, a lot of the same underlying dynamics with underlying domestic violence. There are more same-sex male domestic violence homicides nationally than same-sex female, and I don't think there's ever been a study of them, and that definitely is an important area of research.
Yeah, this is Kate. Oh, go ahead.
Go ahead. No, go ahead.
We didn't ask specifically about suicide in this study, but we did do surveys at our Pride picnics, and we have a pretty high population. And some of the things that we've learned over the years, and again, this has been CBPR work, so it's been largely given back to our own community. I don't believe any of this has moved into press, but one of the things we're seeing is that the rates of physical and psychological abuse are very similar, that the psychological abuse tends to be slightly different and can include things like outing a partner and the like. But what we did see that was concerning in our own community was that gay and lesbian individuals who were being abused were less likely to seek services for a whole host of reasons. So, but again, we didn't ask in those surveys about murder-suicide or suicide.
So we've seen a handful of domestic violence murders with same-sex partners, and I'd say that in those that we've looked at in depth, the dynamics look really similar. We haven't seen murder-suicides per se in that group, although we definitely have seen women batterers using suicide threats as a manipulation, attempt at control, and as a threat against their women partners. And then we also have seen, there's one case involving a woman who was killed by law enforcement responding to a domestic violence assault of a woman against her woman partner. So a lot of the very same dynamics. I think that that's the important distinction, is looking at when you're looking at broad-based groups of people, recommendations, that the large majority of abusers in heterosexual relationships, almost all are those that are at risk for murder-suicide are men. But when you're looking at same-sex relationships, that doesn't apply. So it's not looking at whether this person is a man or a woman, but looking at, is this person using violence and control against their partner, or are they surviving and responding to and resisting a pattern of violence and control by their partner against them. And those screening tools are important when you're looking at who's at risk.
Okay, we have another question from Teresa. Do protective orders work in reservation communities? She also has a follow-up question about tribal college suicide prevention programs and about if all of this is a good approach. I don't know if any of you would like to take that question.
Well, I don't think there's one answer to whether protection orders work on reservations, but there are definitely many problems with the enforcement of protection orders that are issued by tribes that we hear from tribal advocates and survivors that those orders aren't always enforced by the authorities, the county or the local or the state authorities, and there are lots of reasons for that, but it's a big problem.
I do show one question over the phone.
Okay, go ahead.
The question comes from Susie. Your line.
Calling because we work with people with severe and persistent mental illness, and as such, they can frequently experience suicidal symptoms. And at this point, we have no clients who are in a domestic abuse situation, but we do have clients who are in what I would label dysfunctional relationships. And I'm wondering if you have any information regarding suicide, homicide risk for people who are not necessarily in a domestic abuse situation, but their relationship is not as healthy as it could be.
This is Kate. I'll just share a story with you. There's a colleague here who is a minister, and he tried to do a talk on intimate partner violence, and he labeled it in a way that nobody really came. And then he created the same talk with the title Radiant Relationships, and the room was packed. And I think when we're working with clients where there's trouble and conflict, but it hasn't risen to the level yet where there's violence, I think sometimes letting the client know kind of those warning signs and using some of the resources that are out there and talking about the power and control and where some of that can lead. I think and I find as a provider when I'm working with someone when my warning signs are going off and I hear those little bells in my ears, and they'll say, well, he or she doesn't hit me yet, and they'll start to do, my colleague Mike Thomas used to call it the yeah, but he doesn't do that yet, or yeah, but she doesn't do that yet. So, I think screening for suicide and suicidal ideating among those individuals is warranted from my perspective.
I would echo that and just say that it's really important to be focusing on and looking for things like jealousy and control, and that there are that doesn't always get defined as domestic violence. And somebody may not identify that domestic violence is happening. There may not be any record. There's no police report. There's no nothing criminal has happened. Maybe no physical violence has happened. But if those things are in place of the jealousy, the control, the isolation, that I would say that's where the danger is.
Operator, do we have any other questions in the queue?
No further questions at this time.
Okay, and let me remind you, if you'd like to type in a question and answer, you can do so on your screen at the top of the bar in the Q&A box.
I have a brief comment for the caller about issues with protective orders on Indian country. We're hoping that the new VAWA legislation will really substantially improve a lot of law enforcement response and also services on Indian country.
Thank you. That's a good point.
And this is Richard McCann from SAMHSA. Let me just mention that probably the approach to suicide prevention in tribal communities that has the strongest outcome data in terms of reducing suicide attempts, not deaths necessarily, but they looked at when you combine suicide attempts and suicide deaths, they found a reduction, was a model that was developed in partnership with tribal communities at the University of New Mexico by Phil May and Lamira Debrin from CDC and Pat Cerna. And that suicide prevention approach also included a significant work being done around domestic violence as part of that approach. And so it might be useful to be looking at that. There is a dissemination manual for that program that is available on the SPRC website, again, which is www.sprc.org. And if you have any trouble finding it, you'd be happy to, you can email Chelsea. We'll make sure we get that information to you. But like the Air Force model that Jake mentioned, there are a couple of intriguing examples of some work that suggested that there could be real benefit by looking at these issues together and not siloing them as if they were completely different and didn't have areas of significant congruence.
And this is Chelsea. I actually have a question. This one's just from me. You've all touched on the presenters, and actually this question goes out to all of our attendees as well. We've talked about a number of sort of critical issues at this intersection between suicide prevention, and intimate partner violence. But are there any areas for all of you that we haven't touched on? And this goes, in terms of research, clinical practice, things the public should know about, public policy issues. What would you all highlight as being the most critical? And again, this question also goes out to attendees, so if you're interested in commenting, you can hit *1 to open your line or type in the Q&A box. But I'm just interested to hear what you all have to say about that.
This is Kate. I think one of my dreams would be figuring out how to communicate across silos. And even with some of the models where we have attorneys placed in health agencies, or we have providers in medical, legal, or some of the family justice centers have done a better job with this. But I think trying to figure out among college populations, how does FERPA and how does HIPAA and all the cloaks that we have around our shoulders with the information that we're the keepers of, how do we build those coalitions? And Jake, I'd love to talk to you more about how you all have done such a brilliant job of sharing across silos and the work that you're doing.
This is Mary Louise Kelly, and I would like to jump in. First, thank you to the panelists for great presentations. If we're talking about what our dreams would be, I think one area I'm concerned about is the capacity of the field to respond to the identification of intimate partner violence, to the increased screening and assessment that could happen and should happen. So I think we need to pay attention to the need to build the capacity of providers to know how to handle a disclosure of intimate partner violence, how to make the connections to the programs, the capacity of those programs to be able to respond, because we're talking about domestic violence programs that sometimes are unable to respond because they're of shrinking budgets. And the other concern, of course, in terms of capacity to respond is, unlike services for victims of domestic violence, I'm not aware of a national hotline that is designed specifically for perpetrators of abuse to get the help they need. Now, the National Domestic Violence Hotline certainly takes calls from perpetrators and is used to making those referrals, but there isn't the same kind of systematic federal funding for batterer intervention programs or other kinds of interventions for perpetrators of abuse. And I think it's a policy issue, a capacity issue that is worth future discussion.
This is Jake. I absolutely echo that, and I think that it's not clear what the intervention is for batterers that is effective, and that can be effective early, and that can be effective, before somebody is the violence is escalated to the point where there's a homicide risk and a suicide risk. We just don't know what that is, and the batterer intervention programs that are out there are very mixed in their results. The research is real mixed, and most of that is working with batterers who have been convicted of a domestic violence crime, which happens, way far into the abusive relationship. It doesn't happen off the bat, and so that may not be the best place. The best time and place to intervene is at that point where somebody has been convicted of an assault, and those are court ordered. So how do you actually get interventions that work and that can work early, that people would voluntarily do, that don't rely on the criminal legal system? We just don't have a good answer for that, and without that, I think it does lead us to real questions of when we do this screening, when we try to identify where who is using this kind of violence, well, then what do we do about it?
I definitely agree with Jake, and especially the fact that many of these perpetrators are survivors of childhood abuse and other trauma that, that needs to be incorporated in our offender or abuser intervention programs. And then we also need to pay attention to the growing numbers of girls who are using violence in their dating relationships, and in terms of what we do to prevent that, which can later on turn into one of these tragedies. I also just wanted to mention on the Indian country perspective is that we are getting published a study that shows that one of the major risk factors for suicidal youth on Indian country is seeing their mother beaten by a partner or someone in the home. And so, you know, another connection with suicide that's oftentimes not recognized.
So we, I think, have time for about one more question, and Rosemary asks, I'm interested in intimate partner violence screening and prevention in schools and colleges. The screening at student health centers and employee assistance programs at a college, for instance. Also, on a separate note, there's a concern not only for children with domestic violence, but also for pets and violence towards animals. So I guess if anyone could speak to violence screening and prevention in schools and colleges.
I'll just say that I think that the prevention, making a shift toward prevention is extremely important, and it does, you know, it leads to these questions about we know pretty well how what interventions work for survivors, that advocacy is the thing that works, and that's something that you can do with people before they are being abused, because the essence of that is putting a person in charge of their own life. That's what advocacy does. That's that is the intervention that works, is bringing the self-determination back to a person who's had that taken away from them. But when it comes to how do you prevent and how do you stop somebody from using violence, from using power and control against a partner, again, we just haven't quite figured that out. And I'll echo what Mary Louise said, too, about the capacity, that when we're looking at prevention, it really brings up the question of what's the capacity of advocacy programs to do that, who are already really at capacity with the crisis intervention work that they're doing.
Okay, so I think that, operator, do we have any more on the line? Any more questions?
I show no further questions at this time, ma'am.
Okay, well, that is perfect. It's just about time to wrap up. So I want to thank all of our presenters and some of our presenters from the 27th who generously joined us today. And for all of the attendees, thank you very much, especially for sticking with us during some of our technology hiccups. So with that, operator, you can turn off the recording.
This is
Thank you, everyone.
Conference. Thank you for participating. You may disconnect at this time.
And